Hello, everyone, and thank you for tuning in tonight. I'm Paul Hewitt, Director of the IMF's Veterans Against Myeloma program and a member of our InfoLine team. The slides for tonight's presentation are available at www.myeloma.org, and this teleconference is being recorded and will be available for replay on our website. Tonight, for our first ever Veterans Against Myeloma teleconference, we are thrilled to introduce to you two esteemed speakers, Sandra Kurtin and Susan Leigh. Sandra is a nurse practitioner at the University of Arizona Cancer Center and a member of the IMF's Nurse Leadership Board. Susan, also an RN, is a retired lieutenant from the United States Army, a Vietnam vet, and a founding member of the National Coalition for Cancer Survivorship. We'd like to thank our teleconference sponsors, Celgene and Takeda. And now, I welcome Sandra Kurtin and Susan Leigh.
Thank you, Paul and Ian, and welcome everybody. Good evening. My name is Sandy Kurtin, and I'm going to start the evening. And what I'd first like to do is share with you some information that the IMF obtained through a Veterans Focus Group and an online survey. So if you can go past the title slide, what you see here, where there were two groups of people, one at the Veterans Focus Group that was held in Boca Raton, Florida, and the second was an online survey. And from this, we learned a great deal from a number of people across different components of the military. Average years of service varied anywhere from 2 to 37.5 years, and there was a nice distribution of different parts of the service. Some of the quotes that we captured from those surveys, the first saying, I started having fatigue and a bloody nose about 2 months before I was finally diagnosed with multiple myeloma. I love the next quote, this is an interesting disease. No 2 days are the same because the disease symptoms often manifest differently, but you can live with multiple myeloma, and that's really what we want to focus on particularly tonight. The next being, I'm looking at the whole broad spectrum of multiple myeloma. I need as much information as possible, and so we're going to do what we can in the short amount of time we have, and also really try to connect you to the enormous number of resources that exist on the IMF website and within the IMF personnel. So if we go to the next slide, one of the questions we asked is, how do I know if I'm getting the best care for multiple myeloma? We saw that the people that participated in this survey received their care in a variety of ways, many through the VA system only. Some had combined models through the VA system and community care. Many who received stem cell transplants were referred to outside transplant centers, and so again had this combination. But overall, 66% of those surveys were either moderately or highly satisfied with their care in the VA system. So that was good information to have. If we go to the next slide, some of the topics of interest, and we're going to try to touch on some of these tonight, were risk factors for myeloma in veterans, other diseases that are related to multiple myeloma, how to evaluate exposure during service. So I have some good information for you there. The different kinds or types of myeloma, and we're going to do a very brief overview of some of the key elements of multiple myeloma, obviously not knowing for all of you where you fit in that continuum. And then we're going to talk a little bit about some of the updated criteria for the diagnosis and treatment of multiple myeloma before we get into survivorship information and how to be well. If you go to the next slide, some of the things that we heard, going on are the current guidelines for treatment. Symptom management was a big thing, and then how to stay well. Access to benefits and resources on the next slide for veterans was really a predominant theme, and you'll hear from Susan Leigh the tricks of the trade, if you will, and some ideas about how to gain access to resources and advocate for yourself. We also heard about other organizations that people found to be helpful, and I'll summarize those for you in a moment. So if we go to the next slide, I think this was a question that people really, spent time answering here. And so this summarizes the responses to exposure during service. And you can see on the left of the slide, if you have those in front of you, that Agent Orange was by far the most common exposure in this population of veterans who have multiple myeloma. There was also radiation, asbestos, contaminated water. This was some reference Camp Lejeune, for instance. The burning pits or burning waste were mentioned, and then chemical exposure from other sources, and some people not knowing. There is a wonderful blog, and you'll see it in the upper right-hand corner here, that Dr. Brian Dury has put together very recently, just in earlier this month, based on a publication in the Journal of the American Medical Association that really summarizes very nicely what we do know to date about exposure and the development of MGUS, monoclonal gammopathy of uncertain significance, and multiple myeloma. So I'd encourage you to check that out. You can find that also on the IMF website at myeloma.org. Some of the other things that we learned, and just briefly summarizing that survey, was that myeloma often occurs later in life and is often not readily considered as a diagnosis in the initial stages of workup. So it can be pretty vague. People are tired, they may have some bone pain, they might be getting recurrent infections. In rarer cases, we see people that present with a fracture of a bone for no apparent reason or minor injuries, and so it can take a while to figure it out. We learned that veterans utilize care both within and without of the VA system, as I've mentioned, that not all veterans have access to myeloma experts at their treatment centers, and that is something that we talk about, in that getting an expert opinion at least once is probably a good idea. Most of the veterans are not involved in clinical trials. That's not really different than the general population, where the percentage of people involved in trials is fairly small across the country. The process of obtaining disability can be challenging to navigate, and we understand the need to educate both the veterans, the physicians, and the disability administrators in trying to remove some of those barriers, and that veterans are eager to learn what they can about multiple myeloma. On the next slide, you'll find probably one of the most amazing resources for patients and even providers, frankly, that may not be experts, that really goes through nuts and bolts of multiple myeloma. So this is called the 10 Steps to Better Care. And each of these numbers on the website, if you click on it, open up an entire library of information that take you from how do you actually get the diagnosis, how are you sure that that's correct, and then from there, how do you decide on treatment, what kind of supportive care do you need, do I need a transplant, yes or no, what about clinical trials, and just really all the information you need to navigate that disease. So I would really encourage you, if you have specific questions, to check out that site specifically. It's edited all the time, so as new things become available or if there are changes, this is updated in real time. So it will get you the most current information that's really directed at the patient and their caregivers. So I'm going to spend just a couple minutes going through some of the basics of multiple myeloma, and so those of you who are highly seasoned myeloma survivors, bear with me here. But I think for those of you who may not have just had a simple overview, multiple myeloma is a disease of mature plasma cells, and plasma cells produce immunoglobulins, which are basically a major part of your immune system. And these immunoglobulins are proteins. And you can see in the right-hand side of the slide here that you have IgG, IgE, IgD, IgM, and IgA. You can see they all look very different. I always describe these as snowflakes. They're all a little bit different. You can see that IgM is quite large, as is IgA, compared to the other proteins. And that sometimes has a lot to do with what we see clinically. And then we name these proteins based on the heavy chain and the light chain. So the big Y is the heavy chain, and that's in the blue without the red outline. And those are the things that I've just mentioned. And then the light chain are these little proteins that are off to the side of the upper Y that are kappa or lambda. So when you're diagnosed, we figure out what is the heavy chain that you're making too much of and what is the light chain that's overexpressed, and we name the myeloma. So you may have IgG kappa, IgA lambda, IgA kappa, or in some cases, which is much less common, you may only have light chain disease, and then you have either kappa or lambda light chain disease. But that's how the disease gets named, and that helps us understand what to measure in the blood to see how you're doing over time during treatment. If we go to the next slide, this is adapted from a slide that Dr. Dury produced many, many years ago, really looking at the disease trajectory. And what we know about multiple myeloma is that it generally starts as either MGUS or smoldering multiple myeloma, MGUS being monoclonal gammopathy of uncertain significance. And there are different things that can happen along the way that promote those abnormal cells to becoming actual malignant cells or active multiple myeloma. And so NDMM stands for newly diagnosed multiple myeloma. We then treat the disease and we suppress it, hopefully effectively. And then people have a variable duration of disease plateau or response. But relapses are common and in most cases inevitable. And so it's very important when we're looking at treatment that we try to do our best job up front in getting the disease under control effectively at each stage along this continuum. If we go to the next slide, part of what we look at when we're trying to diagnose the disease is now what's called myeloma defining events. So the CRAB criteria, which you may be familiar with, you can see stands for calcium, renal, anemia, and bone disease. If you think about those big proteins we talked about, one of the things that they can do is they can attack the bone themselves, and that lets the calcium out of the bones, and we can see high calciums in patients. Those proteins have to be filtered through the kidneys, and if you have a lot of large proteins, the kidneys basically get plugged up and they don't work very well, and so you can see abnormal kidney function or creatinine. Because these cells originate in the bone marrow, they can also affect your ability to make red blood cells, and we see some anemia, and then the bone disease that I've mentioned. So that stands for CRAB. More recently, based on a paper that you see referenced here in November of this past year, 2014, we now know that some people don't have those what we call end organ damage criteria, but they may have a lot of bone marrow plasma cells, greater than 60%, or those light chains may be very high, or we may be able to see just isolated lesions in the bone by an MRI, and we're really seeing this more as active disease today. There's a lot of research going on to clarify that. So if we go to the next slide, in newly diagnosed multiple myeloma, we really try to tailor therapy based on what we've just talked about. What is the type of myeloma you have? What kinds of end organ abnormalities are there or not? How well are you otherwise? Are you eligible for a transplant? We look at comorbidities. Do you have diabetes, hypertension, lipid problems, arthritis? How fit are you? Age plays some role, but it's not the primary deciding factor. We really focus much more on how well you are or not, other than the multiple myeloma. We also want to know about your caregiver situation. We understand that this disease affects everybody, the patient obviously primarily, but all the people around them. Finances, we're going to talk a little bit more about that later. Transportation, the coming and going. And so we really want to look at the whole picture, and patient wishes play a very important role, obviously, in all of this. So the general approach to treatment then, on the next slide, we want to estimate your risk based on your individual myeloma attributes, based on the things that I've described. We do what's called risk-adapted treatment. So based on the type of disease, how aggressive the disease is, and some of the factors that we look at in the chromosomes and now molecular attributes of the disease to tell us how aggressive that disease might be and what the prognosis might be for the individual patient. And we select the therapy based on that information, so it really becomes tailored for each individual patient. We hope to achieve an early and deep response. So if you go back to that trajectory slide and you see the slope down, we want that to go way down and quickly. That's going to produce the best and most durable response in most cases. We really want to prevent any adverse events or side effects, and we really rely on you as patients to help us do that by keeping track of your information and reporting that to us so that we can intervene early before anything gets to be too severe so that we preserve future treatment options. Maintaining a durable response, a lot of the work today is looking at how do we keep people in that optimal response for as long as possible. And so we see a lot more maintenance therapy or continuing therapy in patients with or without transplant. And then we want to be sure we understand when people are losing their response so we can move to other options. And then always trying to maintain or improve quality of life. The next slide shows that thankfully in the last really now almost 2 decades, or certainly the last 15 years, we've just had a very robust development of treatment options. And so this is a wonderful thing to have in that we have so many choices. It does produce sometimes some confusion or lack of clarity for patients because there are so many choices, and depending on where you are in the country or the world, people may have different things that they choose to do first, second, or third, and there really is not a consensus in terms of what goes in what order. And there are people in the IMF and in the International Myeloma Working Group that are trying to really hone in on does that matter and what is the best way to start and go second, third, and fourth. So it's important to understand that the science has not yet answered all of those questions, and it's always just really good to ask your providers for their rationale in doing what they're doing. The good news is, if you move to the next slide, is because of all of these new compounds that we've had in the last 15 years, we've seen an enormous improvement in survival between the years of 2001 and 2005 compared to 2006 and 2010. And I think if we look at more recent years, we're going to find that this trajectory looks even better. So we're seeing extended survival, which is what makes survivorship, which you're going to hear about shortly from Susan, so important, is how do you stay well so that whatever the next available option is, it's an option for you, and taking care of yourself and being your own advocate. Now, all of those drugs are great, but they all do have some trade-offs, and so it's very important to acknowledge that they all have side effects. And I don't have time to go into this in great detail. This is a slide that comes out of the International Myeloma Foundation Nurse Leadership Board patient and family education deck, which we provide to support groups and often present at support groups, and can go into in great detail if you have additional information. So I encourage you, if you have a support group and you haven't had a presentation, to inquire about that, because there's a lot more time to go through this in great detail. There are a lot of recommendations for supportive care or adjunct care, if you will, in multiple myeloma, which is the next slide. So all of those things we talked about that are part of the diagnosis, the bone disease, the calcium, the anemia, the risk of infection, come with recommendations for how to support patients in keeping those things at bay. And so it's very important to take a look at this and make sure that you're doing all that you can to manage those extra problems, particularly getting immunizations with the exception of a live vaccine or the herpes vaccine. So what can you do? Seek out resources. You're doing that tonight by joining this webinar, and we appreciate your time. Really look to your health professionals, ask questions. The support groups, as I've mentioned, be a partner in your care, participate in decision-making, really take the time to learn all you can about myeloma and your particular individual situation so that you can advocate for yourself. Tracking your treatment, keeping track of what's happened over time, including your treatments, but also any side effects and how you've managed those is very important, particularly if you're a person who may spend part of the year in one place and a second part of the year in another place. We're in Arizona, so we have a lot of winter visitors, and patients really are their best advocates when they have their information over time, because we don't always have access to that as providers. As I mentioned, get immunized with the exception of live vaccines, and then take part in wellness activities like diet, nutrition, and exercise. Staying well is really so critical to making sure that you are able to have access to the next best thing, if you will. There are a number of resources on the IMF website. I mentioned the myeloma.org site. I will also mention the 1-800-452-CURE, which is a hotline that is manned by some remarkable people, and this can serve a lot of your needs and just trying to locate resources or answer questions. So do take time to look at that. On the next slide, we look at all the patient education tools that are available from the IMF, and these are updated regularly, and if a new drug becomes available, they create tools very, very quickly, and these are really intended for the patient and their caregivers, so it goes through a lot of great information for you. These are just some more examples on the next slide, and again, I would recommend that you take time to look at the 10 steps to better care. All of these have live links, so if you're on the web page, or you can click and move around like you're in a library, and again, if you have trouble, I would recommend that you call the helpline and they can help you further. And then each of the companies that manufacture drugs also have assistance lines, so if you need additional information about specific drugs or some of their assistance programs, you can visit them there. The next slide just talks about some of the resources that the veterans in this survey talked through, which included the American Legion, the Disabled American Veterans, Veterans of Foreign Affairs, National Association of County Veteran Service Officers, the Marine Corps League, the State Veteran Affairs Boards, and there were many different states mentioned, so I didn't list them all on the slide, but if you just put in that in your state by Google, it comes right up. The U.S. Department of Veterans Affairs and the Military Order of the Purple Heart, and these are all the links to those websites, and then also advocacy with local politicians, just making sure that they're aware of anything and advocating for you. And with that, I will now turn this over to Susan Leigh.
Good evening, everyone. I'm just so pleased to be here to talk to fellow veterans. I've done presentations all around the country and some internationally, but I've never actually done anything for my fellow veterans. So welcome, and I hope that I can give you some of the insight that I've gained over the last 40-some years since I've been a cancer survivor. Just a little bit of history for me. I was an Army nurse in Vietnam from 1970 to 71, and came home and was diagnosed with Hodgkin's lymphoma. So I have a form of a blood cancer. I had a form of a blood cancer, but not multiple myeloma, so it's very different. But because of that, it really encouraged me to take a look at this whole area of what happens after we're diagnosed and treated for cancer. And this was 1972 and later, and there was nothing available at that time. So to see the growth in advocacy over the last 4 decades has just been absolutely amazing. So I'm going to go ahead and take a look at what my goals for today are. And it really is enhancing the quality of life after a diagnosis of multiple myeloma. And Sandy certainly encouraged this in her presentation too. And please excuse my raspy voice. I do have a bad vocal cord, so but we're all cancer survivors, so a little raspiness isn't going to hurt any of us. So what I'd like to do is explore the dimensions of advocacy and how you can become your own best advocate. No matter where you're treated throughout the country, whether you're in a Veterans Administration hospital, whether you're in an academic center or a community practice, you're going to have to be your own best advocate. No one has all the resources necessary for you to really explore this whole area of advocacy and survivorship. So we really need to see who's got what, and that's really what we wanted to do today, is learn how to advocate for yourself and find this type of information, and then to optimize access to and the use of appropriate resources. Just because you find something online on the web does not mean that it is good information. So I was so pleased to take a look at the IMF web page, because let me tell you, it's probably one of the best put together web pages that I have seen, and I've seen a lot of them since I tend to be a generalist advocate as opposed to a specific cancer. So the amount of information and the accuracy of the information is really, really top-notch. And then I want to introduce the continuing need for follow-up care and take a look at survivorship care planning. And Sandy also alluded to this. We really need to keep track of the information that we collect during our survivorship journey. Incredibly important, and I'll be talking more about that later on. So the next slide just starts taking a look at how we're going to be defining our population. There are many, many ways to define a cancer survivor, and I kind of will use cancer survivor and cancer patient interchangeably. But with those with multiple myeloma, how are you actually defining yourself? So who is a cancer survivor? And on this page that you can see some photographs, I actually recently found a picture of myself that one of my patients had taken years ago. There's even a little tear in this old photograph, but that was me about 45 years ago in Vietnam. And even though I've gone through treatment for Hodgkin's disease and then breast and bladder cancers, and now I have cardiac issues that I'm dealing with that are related to many of my treatments, I'm still so thankful that I'm here to even have these problems, because I can be sharing a lot of the information that I've gathered over the last 4 decades. So I look at the luxury of labeling. Since NCCS, the National Coalition for Cancer Survivorship, of which I was one of the founding members in 1986, we coined this term cancer survivor for in a very different way than had been talked before. And then over the years, I've heard people say, well, I really don't like being called a survivor. I want to be called this or that. And so I started keeping a list, keeping track of all the different ways that people wanted to be labeled. And I say, fantastic. However you want to be labeled is just fine. And isn't it wonderful now that we have the luxury of arguing about what we want to be called? So but survivor is the term that I will be using for the rest of the presentation. And there are different pathways to survival. And the next slide shows that just because a person finishes their initial course of therapy doesn't mean that they are going to be in the same situation that someone else is going to be in. So these are just a few of the ways that people can live their life after their initial diagnosis and treatment. In fact, some people will remain cancer-free for the remainder of their life, probably not with multiple myeloma, but with some of the other types of cancer. You can live free for many years, but experience one or more serious late complications of treatment. And we know because of collecting information and data, that those of us who are treated for Hodgkin's lymphoma, the females anyway, had a much higher risk of developing breast cancer. And so I I did experience that, and many of the other survivors that I know are going through the same thing. We can also live cancer-free for many years but die after a late recurrence of the disease. We can live cancer-free after the first cancer is treated but develop a second cancer, such as I did. And then the last two that are starred are the ones that I think are particularly appropriate for someone with multiple myeloma. And that's living with intermittent periods of active disease requiring treatment, or living with cancer continuously without a disease-free period. To those of us at NCCS, the National Coalition for Cancer Survivorship, we're all survivors. Everybody in this list is considered a survivor. It's just that we have different issues that we have to deal with. So when I took a look at defining survivorship on the next slide, the original survivor definition came from pediatrics. Actually, it really came from the insurance companies. The insurance companies originally said a cancer survivor was the loved one left behind when the patient died, because originally everybody who was diagnosed with cancer died. We have moved so far away from that now that a number of years ago, pediatric oncology said, well, if our little kids can live for 5 years after their diagnosis and treatment of cancer, we're going to call them survivors. At the very end of this slide, I look at the stage of survival, and many in the medical community have decided that a survivor is somebody who's completed treatment and has no evidence of disease. Those of us in the advocacy community say we really do look at survivorship as a process of survival. It starts at the moment of diagnosis and continues for the rest of our life, no matter how long that life may be. And so all of us are survivors going through different stages. The next slide looks at the focus for today. So I'm going to look at the advocacy perspective, VA perspective, and the civilian perspective, both academic and community clinics, looking at how survivors are treated in different areas and how we can share information from all these different perspectives. So the next slide then looks at where do I start? And you got a lot of really, really good information already from Sandy. But for me, you start with the oncologist and oncology team. When you're first diagnosed and you see your oncologist or your oncology team, whatever provider you're seeing, this is where you start getting the major amount of information. You won't get everything from them because there's no way that they can know everything about all of the disease processes, the treatment options, and then all of the advocacy issues. But certainly they are a good place to start. And then if you can get to that International Myeloma Foundation website, you're really, really far ahead. And no matter whether this is your first diagnosis or if this is a recurrence of disease, there's an incredible amount of information at this site. And I'm just blown away at the Veterans Against Myeloma website that we actually now have something specifically for veterans when it comes to this disease. And I'm sure that this site is going to continue to grow and offer all kinds of information to all of our veterans. And then the National Cancer Institute at cancer.gov is an incredibly reliable source of information. And I think when it comes to advocacy, we really need to encourage looking for reliable information, reliable sites. And that's what we hope to share with everybody on this in this type of a program. So moving on, looking at the advocacy as a consumer issue, this is all information that we have created at the National Coalition for Cancer Survivorship, or NCCS. And we have looked at advocacy on a number of different levels, but the area that we really need to focus on at the very, very beginning is learning how to be a self-advocate, and what does that mean? And now I've been in the VA system since 1972. I've seen tremendous changes within the VA, and especially in the area of women's health. I don't know if there are any women on this call, but I'm sure you've seen tremendous progress when it comes to taking care of women. But really, we do need to learn how to advocate for ourselves. And actually, when I look at any patient going into the hospital, I really firmly suggest that you have somebody with you for as much time as you possibly can. So we'll look at self-advocacy a little bit, the community advocacy, and the national and public interest advocacy, and then legislative advocacy. So what is self-advocacy? The next slide says that self-advocacy does not mean that you have to wave a banner, give speeches, or take to the ramparts. In the personal context, it means that you arm yourself with the tools and skills necessary to feel comfortable about asserting yourself and communicating clearly about your cancer care needs. It ultimately means that you are taking responsibility and assuming some control of your life circumstances with cancer. Now, what we've also realized is that not everybody can be a good self-advocate or wants to be a good self-advocate. Hopefully you have somebody close to you, a spouse, a child, a good friend who can be that advocate for yourself. And with some of our folks who are from different cultures, if you come from some of the Asian cultures, it's not appropriate to be a self-advocate, but boy, they have incredible advocates in their family members. So it's just a matter of identifying who the best advocate will be throughout your experience with multiple myeloma. So some of the self-advocacy skills that we've identified is how do you ask the right questions. That probably is one of the biggest issues when somebody first hears that they have cancer, and especially something as complicated as multiple myeloma. What questions do you ask? How do you find the right information? Who do you actually talk to about finding information? And do you understand the answers? This is a big one. We can get all kinds of information from our healthcare providers. Do you really understand what they're saying? And that is one reason why we really hope that our treatment plans are written down so that we can refer to those after we leave the clinical setting. And then how to communicate effectively. How do you let your healthcare providers, your family, know that you have questions or you have concerns? You have symptoms that you need to be dealt with. You need to know how to ask the questions yourself. How do you make decisions about your care? Taking a look at the slide that Sandy showed us with all of the different options for care, it's amazing how some providers will say, well, I've got these different options, now you make the decision. And so how do you make decisions, or how do you ask people to help you make the decisions? And how do you negotiate your care? These actually are basic skills that were identified by social workers who worked with the National Coalition for Cancer Survivorship. And we now have a program called the Cancer Survival Toolbox, Building Skills That Work for You, and this is available through canceradvocacy.org. Excuse me. You can go online. You can actually ask for a CD to be sent to you. Some people do not have computers at home. Some people don't know how to work a computer. And if that's the case, we can actually send you a CD so that you can listen to it at home. You can also read the text online or listen to the program itself. And some examples of self-advocacy. First of all, know your oncology team. Oncology is probably one of the most complicated team efforts that you can have for being treated for a specific disease. You have medical oncologists, radiation oncologists, surgical oncologists, and then your nurse practitioners and your PAs and your RNs and your social workers. There are all kinds of people on your team. Have somebody along with you to write down who all these people are if you don't get this information given to you. Ask about resources. One thing that the VA has that many, many community practices do not have, they have social workers. They have case managers. You have access to dietitians. They probably don't have navigators nearly as much as some people in the community do. But there are a lot of people who can do the work of the cancer navigator and get information to you. When you've got all this complicated information, you have a complicated case, hopefully your social worker will be able to get you to the right people to find out what kind of assistance you can get or what you're eligible for. Excuse me. And get second opinions. Again, you may not want to stay within the VA system. Maybe you want to go to the nearest academic center, or you may want to, call some place online, but you find out what your second opinions are, and especially when you have complicated decisions to make. Many of our VAs are affiliated with academic centers, so this has become much easier than it was before. Keep track of your medical records. Excuse me, got to take a sip of water. Keep track of your medical records. Again, Sandy mentioned that you may be leaving, going from one home to the next, or you may be moving to different parts of the country. it's really important that you have the information that you can actually take with you. So get a binder and accordion file and just keep track of all of this. You can go to the Release of Information office at any VA, and this information is available to you free of charge. You just have to let them know specifically what you're looking for and the dates, such as you had a CT scan and on the date that the CT scan was on, or at least the month, and they'll find that for you. And another wonderful program that the VA now has is myhealthyvet.va.gov. And the My Healthy Vet is, your own site looking at keeping track of what is going on with you, and you can find out what your blood counts are. You can find out who your providers are. It's just a really good place to have your specific personal information. And then, if eligible, utilize Medicare and TRICARE for a care outside the VA. I went up to Stanford for a second opinion for my cardiac issues since they were cancer treatment related, and not everybody has seen this. So I went there because I just wanted to make sure that the VA was covering all bases. And what I heard from the cardio-oncologist at Stanford, who's a specialist in this area, has been seeing Hodgkin's damaged hearts for a long time, he said to me as soon as he saw me, he says he couldn't believe the quality of care that I was getting at the VA here in Tucson. That made me feel really, really comfortable. So I used Medicare as a primary and TRICARE as a secondary since I am over 65 now. And it was very, very easy to get that kind of a second opinion and to go up there for that information. And then look for support services in your community or online. There are so many community resources that are available now in many, many of our communities. Certainly, the larger your city, your town or city is, the more resources you'll have. See what you've got. If you don't have a lot available, then go online and see what you can find when you give, once again, credible information by getting help through the kind of information that we're giving you today. But there's a lot available online. And so we can actually get that kind of support, and especially when you're in a very rural community, that certainly isn't going to have the numbers of people needed maybe to have a support group. The next slide takes a look at some of the topics for the NCCS Cancer Survival Toolbox, and I'll just, that we already went over the basic skills, and we're going to really be focusing today on finding information and standing up for your rights. But I'd like to take a look at the down towards the bottom. There's a module that you can get that's Living Beyond Cancer. And this is one that I had really encouraged us to create information about, and that is, what do people do when they finish that initial course of treatment? Those of you with multiple myeloma, many of you, most of you, will have different treatment options throughout your lifespan. And so this really talks about living beyond cancer and beyond that initial diagnosis. And then the Centers for Disease Control gave NCCS a grant about a decade ago. They wanted some disease-specific information about some of the blood cancers. So we do have a module on living with multiple myeloma. Not nearly the detail that you're going to get from the IMF and the type of information that you got from Sandy, but it has a lot of information about advocacy and how to deal with the many social and financial and spiritual issues that go with being a long-term cancer survivor. The next slide just is an example of what you can do with community advocacy. So many people get to a point after they've been on this cancer journey for a while, they say, geez, I'm kind of tired of just thinking about myself. I'd like to give back. I want to do something for other people. And so we kind of go to the next level of advocacy. We call this community advocacy. And this is where you can really tap into all kinds of materials that are available in your community. And I think when we get to the community advocacy, what I'd like to say is, if you have fellow veterans with multiple myeloma who may not know how to use a computer or don't have access to one at home, you can then be a community advocate, a fellow advocate, and say you could help them. So that's just a great example of community advocacy when you're doing something besides being a self-advocate. The next slide shows some examples of being a national advocate. This is where you can get involved with the advocacy organizations. You can get involved with IMF, and there are all kinds of ways that you can get involved there. And I'm sure if you call the office, somebody's going to find out all different ways that you can be involved with this organization. There's the National Cancer Institute, and you can be consumer advocate right at the top. You can be consumer advocate for some of the local boards that people sit on. But you can raise awareness through writing, publishing, public speaking. This is really going, to other steps that most people don't really want to get to, and I'm certainly not saying that everybody should be doing this. But I think that this helps many of us who are longer-term survivors feel like there's some purpose for the extra years that we've been given. One of the very last one is raising money for research. This is an area that many people are involved in, whether it's local, statewide, national. So you can get involved, whether it's races or runs or any kind of golf tournaments or whatever. You can help raise money for research. And I'm sure that there are a number of ways that IMF is involved in this way. And then the next slide looks at legislative or public policy advocacy. Probably the fewest number of advocates really want to get involved in this level. I find this is not my thing. It's difficult for me to do public policy advocacy, but it's so definitely needed. We as cancer survivors need to be on these committees and on these boards. We need to make sure that the voice of the survivor is part of any of this decision making. So you can really do lobbying and activism, raising awareness again, collaborating again, looking at passing cancer-related initiatives, testifying before government bodies. And I know there's a site on the IMF website where you can get involved at this level. So I just want to give a shout out here to the founders of IMF. I was introduced to Brian Novus by Dr. Brian Dury back in the late 1980s. I had become involved with the National Coalition for Cancer Survivorship in 1986, and a couple years later, Brian Novus was trying to start a myeloma foundation. So I went over to California and I spent a couple of hours with Brian. And I didn't meet Susie, his wife, at the time, but I was very pleased to have been able to spend the time with him. And of course, I knew Dr. Dury from work here in Tucson for a number of years, so I would do anything for Dr. Dury. So this was a wonderful way to get involved with IMF. But what I am struck by in looking at the website that IMF has put together is that their mission is so totally inclusive. It talks about educating patients and families about this disease, meeting their emotional needs of both the patients and their families, and supporting myeloma research. So many of the advocacy organizations really focus on maybe one, maybe two of these issues, but very, very rarely do you see a complete focus that this organization has. So I'm really very, very pleased to see the growth over these years. And then just to give you an idea about a true advocate, I looked up Michael Katz on the internet the other day. I knew Michael through work on the Directors Consumers Liaison Group. It was the first consumer advocacy group at the National Cancer Institute. He was the chair of it. This man was absolutely the most tireless advocate and probably the most sophisticated advocate I had ever met. So I just want to mention that Michael Katz was very, very lucky to find IMF, and IMF was very, very lucky to find him. So the Institute of Medicine was a report that came out of the National Academy of Sciences, and it looked at cancer survivor issues and says cancer is not a chronic condition, but it's not treated as one. When treatment ends, most survivors do not have a follow-up plan or treatment summary. Surviving cancer is something to celebrate, but it's not the end of the road. And cancer changes your life forever, and it also changes your healthcare needs forever. Now, I'm running out of time, so I need to get through these probably a little quicker than it's easy to listen to. But there are some goals of survivorship care planning, and you can certainly review these on the slide at another time. But essentially what we want to do is we want to try to help us all improve the quality of our lives, and a lot of that means keeping track of our records and finding out what we're supposed to be doing to do this. So the components of the care plan are having a treatment plan. When you have a new type of treatment, make sure that somebody writes it down and it's all written down for you to refer back to. You need to have a treatment summary every time you finish a different course of treatment. Have a treatment summary so that you know what happened, and then look at a follow-up care plan so that you know what to look for in the future. I better probably go through these treatment plans. Once again, treatments are very complex, so get everything written down. The next slide is a treatment summary. There are some templates out there that you can go to. You drop in the information that you've hopefully collected, the names of your drugs, the type of surgeries you've had, and this gives you some really good information about how to move forward. The follow-up care plan really takes a look at health maintenance and health promotion. This is how you can be well after cancer. And this is a whole area. We could have a whole session just on this. So the next slide shows some care plan templates that you can go into to start collecting data and start getting information. But I'm not going to go through them one by one, but I will pay some special attention to OncoLife on the next slide. OncoLife is probably the easiest one for all of you to do. You just have to know the names of your treatment drugs, or the type of radiation that you may have had. And it gives you information about symptom management and what to look for moving forward. There are resources that you can get. There's resources now for cancer fitness for you, yoga, healing walks, dying to know. There are other helpful resources that I put down in the next slide. And what I'd like to pay a special attention to is the myeloma manager, the personal care assistant that you get from IMF. But also look at the one area to look at with the veterans is the U.S. Department of Veterans Affairs, where it really looks at exposure to Agent Orange. So that's another good resource for you. And then the best kept secret in with working with multiple myeloma, I believe, is the Leukemia and Lymphoma Society, because nobody ever really knows that they're working with multiple myeloma, but there is some information there. And then the Multiple Myeloma Research Foundation. You can look at complementary therapies, all kinds of complementary therapies, and this is available in your community. Hopefully you can find something like this available in your community. It helps us feel better, and that's an incredible issue for us when you're not feeling good. The American Institute for Cancer Research has information about diet and guidelines for cancer prevention. And you say, well, it's a little too late for me. It's too late for prevention, but it helps you hopefully prevent some of the problems that you may have with some of your treatments. There are cookbooks that are available. I especially love the ones by Rebecca Katz. Then there's physical health. There's exercise, weight gain, controlling lipids, and not smoking. But I think we have to be very cautious here about exercise when it comes to somebody with multiple myeloma. You can't go out and do everything that everybody else can do, so make sure you really talk with your healthcare providers to take a look at this. Some final thoughts, whether we're treated in a VA, an academic center, or a community oncology practice, we must learn to advocate for ourselves or find someone who can. Resources differ in every community. Know how to find what is available locally, nationally, and online. If resources do not exist in our area, we can help create programs to fill the voids, and we can advocate for ourselves and ask for treatment and follow-up plans, and then we can begin the process of care planning ourselves. So I'm sorry that I kind of croaked through this as quickly as I did, but I'm going to pass it back over to Paul.
Okay, and now we can move into some questions. So if you have a question, Ian, what is the instructions?
To ask a question, please press star followed by the number 1 on your telephone keypad. You may take a moment to compile a Q&A roster. Again, it is star and the number 1 on your telephone keypad. And our first question comes from the line of Leonard Brzezowski. Your line is open.
Hi, I just have a question about coordination between the VA and the local either academic or center of excellence. I'm currently in remission, but don't expect to stay that way. And myeloma drugs are extremely expensive, and especially on Medicare. But I'm sure that the VA treatment is excellent. But I'm fortunate to have a world-renowned myeloma specialist within 30 miles of here, probably 3 of them. Can anybody answer that for me?
Sure, I'll start. This is Sandy, and then maybe Susan can give you a patient's perspective as well. But so we are at the University of Arizona. We have a VA, which is here in Tucson. Our fellows, which are training to become oncologists, hematologists, oncologists, work both in our institution and at the VA. So they go to both places and help with those clinics. And we have faculty who are at the VA, but are members of our hematology oncology department. So we work actually very closely, and I know for myself as a provider, if we have a patient who is service-connected within the VA, that is a conversation we always have, because you're right, the expense can, even, Medicare, the 20% or whatever is left over, if your secondary doesn't cover that, can be substantial. So for those of you who may be in that situation, I just encourage you to bring that up. If you are at a center of excellence, we certainly can make recommendations. If the people at the VA are less versed in myeloma management, and see what we can achieve, which will get you the best of both worlds, in my mind. Susie, do you have something to add?
Yeah, especially if you're service connected, absolutely you're free to go to the VA. And if the VA can't give you the same amount of quality of care that you can get at the university or the academic center, they would send you over there to get it. But there is, I've gotten tremendous care to the VA here. And as an oncology nurse and having worked in an academic center, I wanted to make sure that I had access to as good a care as possible, and I've certainly got that at the VA. And this is certainly an area where you could go to a social worker or somebody in one of the offices there to help you, make sure that you can get into the VA and use whatever kind of assistance you need.
What do you mean by service-connected?
Well, many of the survivors, many of the veterans who know that they had Agent Orange exposure, or some of the exposures that Sandy was talking about, could be deemed service-connected. But you have to go through the VA and go through that process and get service-connected, and then you have access to everything that the VA has to offer for absolutely no cost.
Right, but I'm not service-connected because I served on an aircraft carrier, and the government considers, off the coast of Vietnam, and the government does not consider me to be exposed to Agent Orange, even though I probably was.
Yeah, but you can still go to the VA, and they have different levels of insurability, and you won't probably pay any more with some of the different levels than you'd be paying at any of the other centers. But you can still get your care there and get all your drugs through the VA.
I'm more concerned about the drugs. I'm actually very strange. I've had a mini allogeneic transplant, so I'm an experimental case. I guess you answered my question. Thank you.
Thank you.
Our next question comes from the line of Michael Clower. Your line is now open.
There's actually several questions. Probably don't have time during this seminar. I was wondering, do you have a contact information or something like that we could ask further questions from someone? Because a lot of things I've been trying to look up through the internet, through Google, everything else, and I'm not able to find a whole lot of information.
So I would really encourage you to call the 1-800-452-CURE number. Those people that operate that hotline are extraordinary, and they may not be able to answer your question directly themselves, but if they can't, they will get you to the right people. So clearly there's not enough time within this call to answer everyone's question, but we really do encourage you to contact the helpline so that they can follow up. And the Myeloma for Veterans site also gives you some additional ideas about how to make contact so you can get your questions answered.
Okay. All right, thank you.
Uh-huh.
Our next question comes from the line of Trish Graves. Your line is open.
Hi. My husband is a secondary maintenance for ranch hand veteran, and he has multiple myeloma and a number of other cancers. And we're in Montana. Our regional office is at least 3 to 4 hours away from us, and we're having to deal with clinics. My husband has had a pretty extensive career in the fire service, and he is got really good insurance, and he's got his Medicare and Part B and supplemental through his work. And we're trying to find out if we even have to go to the VA for this, because his oncologist is just amazing. I don't know how we lured her to Montana, but we did. So
are you talking about getting a second opinion, or what are you thinking you need to go to the VA for? I mean, if you have excellent care where you are and you have the insurance to cover that, you don't have to go to the VA.
Okay.
I think it's just if you're comfortable with what you are getting and you have the insurance to take care of that, fabulous. And I'm glad to know. Where in Montana are you?
We're in Victor, Montana. We're a little blink of an eye. We have one traffic light, and it just went in a couple years ago. So
it sounds very cold there, being in Arizona, but I'm happy that you have someone there. And I think that's a really good point that you make, is that there are some really extraordinary providers in the community, and we're not saying don't go there. What we're saying, I think Susie and I both, is that if you're comfortable with what you're doing and you feel like you've investigated and asked the questions, that's great. And we're just trying to help people advocate for themselves and ask questions and make sure that they are comfortable with what care they're receiving. It doesn't mean you have to go to the VA, but they certainly do offer some services for people that may not have access to those otherwise.
Okay, yeah, we've got a case in with the VA. We were denied, and we were C-123 veterans. So when this new IOM determination came up, and more recently on the 3rd of this month, when the release was made with MGUS and myeloma, we were able to pass that information on to the C-123 Veterans Desk in St. Paul because that's where his appeal is being determined. So it's pretty interesting how some of these veterans who have been suffering with multiple myeloma for years and years, they've added 22 new ships to the ships that were in the local waters. And they've also added these C-123 veterans now, so we're really thrilled that all these things are coming about, and that there are men who are going to be able to get service-related treatment, and they won't have to do it on their own.
That's great.
What I'd like to add to that, too, is don't give up. Just keep applying for the disability or whatever you need to have to get into the VA system. I think the VA is much more amenable now to listening to the veterans and trying to get them into the system than they were before. So once again, we have to be squeaky wheels here and keep applying and applying and applying. And I actually had a service-connected disability, but I got nowhere until my parents, because I was back at home after Vietnam. My parents had one of their lawyer friends write a letter, and boy, within 10 days of them receiving a letter from a lawyer, I had a disability. So I think there are different avenues that we can use in order to get the care that we need. but probably the most important thing is that you are satisfied with the care that you're getting there in Montana, and kudos to you. Keep that up, and certainly don't go to a VA just because it may in fact have been Agent Orange related.
Thank you.
And our last question comes from the line of Kenny Littlejohn. Your line's now open.
Thank you. I'm 65 years old, and I'm having to be to do a, what do you call it? Oh my goodness. I'm chemo. I'm having to do chemo on Monday, but while I'm about to do the chemo on Monday, my doctor has presented the process of a stem cell transplant, and there's a West Clinic in Memphis that is now has the capability to do the stem cell transplant, and I can only get that possibility if my insurance will pay for it. Now, on the other hand, I can get it through VA, but I'll have to go to Nashville, to the Nashville VA Vanderbilt Hospital. So my question is, I know there are some situations where if the capabilities, if VA doesn't have the capabilities of doing a service then they will farm that service out to a private individual or hospital. But why not in this case of multiple myeloma?
So it isn't just multiple myeloma, sir. It is all diseases, and transplant programs are contracted, and so everything really comes down to who has the contract for which group. And there are some insurance plans, variations of those plans that can be negotiated. I think you need to count on the people taking care of you at the West Clinic and the people or the where you are in your clinic and the West Clinic to review your case. We have been able to transplant some veterans here. Others have to go to the regional centers in order for the VA to actually fund that completely. It is a very expensive process, and so and yet it's very difficult to be away from home, and unfortunately that's the way the system works, not just for the VA, but for every other insurance plan. So we have insurance plans that only cover transplants at a center outside of Tucson, for instance, and people have to go where they cover them, and that is all based on insurance contracts. So it really doesn't only apply to veterans. For you all, however, the specialty centers for transplant for veterans are fewer across the country, and so the distance you go might be a little bit further than you would otherwise need to go. But I would really encourage you to ask them to check and try and argue the case. It's always worth a try to argue to be at a center closer to home. That's really the best that you can do to try to negotiate with insurance companies.
Okay, and I think that's what they're doing. I was just concerned that it's not already, this isn't already available. So
no, it takes a while to do it. Yeah, and you should start the treatment in the meantime. Get the disease under control. You need to have it under control to have a transplant. So we often work on it while you're getting your therapy in the first place, and it because it does take some time.
Mm-hmm. Okay, well, that is the case, and I certainly appreciate your advice. Thank you.
Thank you for joining us.
Okay, everyone, thank you so much. That concludes our teleconference tonight. I know that there are a couple of questions hanging. Please call the International Myeloma Foundation's info line at 800-452-CURE. That's also 2873. And we would be happy to try and answer those questions for you. We apologize we weren't able to get to them tonight. Please mark your calendars for our next Veterans Against Myeloma teleconference, which will be on November 12th, the day after Veterans Day. Our speaker will be Raymond Gustafson. He's a retired ratings specialist on the appeals team from the VA and a contributing editor at vietnow.com. Should be very enlightening and illuminating and interesting. Thank you again for dialing in. We thank you, Sandy and Susan, and all the participants, and hope you have a great evening.